Chapter 32 is serious mental illness. And we'll talk about what kind of mental illnesses are um, found to be biologically based and how we help people to deal with them. So the definition of serious mental illness, group of disorders, most of them are biological in origin, which means there is a change in the structure of the brain. There is a change in how the neurotransmitters are functioning, and that these disorders affect a person's ability to function, to have relationships with others, to work, and can change their quality of life, especially if they don't have adequate treatment. The book says that this 4% of all adults in the United States, actually in 2014 they calculated that to be 10 million people. I think we know that after the COVID-19 episodes that we've had, that more people have been diagnosed with a mental illness since then, whether it be depression or some other type of illness, especially in young people. So other terms that you might hear that mean the same thing as serious mental illness, broad-based mental illness, and that kind of includes every accepted diagnosis. So that brings in a whole lot of different diagnoses. Severe and persistent mental illness, similar to but not exactly the same. This kind of emphasizes the persistent, which means this is a chronic illness that can't, it doesn't go away. And then the biologically based, which they do have a biological differences in the brain or the neurotransmitters. This slide lists some of the examples of serious mental illness: major depressive disorder, bipolar, schizophrenia, schizoaffective, panic disorder, PTSD, borderline personality and antisocial personality disorder. While not a while a personality disorder, there's still things that are very chronic and consistent with a person. And then OCD, obsessive compulsive disorder, which is different than the personality disorder for obsessive compulsive personalities. So we used to talk about rehabilitation, and that focused really on the problems that the patients had, and just kind of helping them to learn to deal with the problems that the illness caused for them. Treatment was focused on helping them function and just to minimize their disability. Advocacy, especially NAMI, started making changes. A lot of places call their patients now consumers. You'll find that at the nursing homes. They're not patients, they're consumers of a product, which is mental health recovery. Recovery started in substance abuse and kind of developed from there. So recovery, it's patient-based, empowers them to have a decision making in what they would like their treatment to be, what they would like their life to be. It's a partnership with the patient and the caregiver, rather than the caregiver dictating to the patient what type of care they should have. Looking at what the patient can do rather than what they can't do. Encourages them to be independent. Um, they pick their own goals rather than the staff or professionals saying this is what you should do. And we want them to have eventually productive and meaningful lives. So, other issues that are a problem for people who have a serious mental illness. We talked a little bit about how the goal is to establish that meaningful life for themselves. Things that may stand in the way, comorbid conditions, physical disorders. The treatment itself can cause some physical problems, some abnormal movements, metabolic disorders. Some of the second generation antipsychotics cause a lot of weight gain, which can in turn elevate blood glucose, blood lipids, leading to high blood pressure, type 2 diabetes, extra physical problems that maybe they would not have had they not had this mental illness and needed to take these medications. There also may be physical problems simply from the lack of taking good care of themselves because of the illness. Many of the mentally ill or maybe many of the homeless population have a mental illness, and so that type of life can lead you to have more physical disorders than you would if you were a housed person. Depression and suicide, those, no matter what your diagnosis are, depression comes along with that. And anytime that you're depressed, that does increase your risk for suicide, especially if you're feeling hopeless. So that's another issue. And then substance abuse. Um, Alcohol, marijuana, and other drugs. It can be a form of self-medication. Um, at times when people are not taking their prescribed medication, they may turn to substances in order to attempt to manage the symptoms of their illness. Um, Cigarette smoking, well, we don't always think about that as substance abuse. That's been an issue for people with mental illness. Um, Nicotine can be used to self-medicate also. And years ago, we used to provide cigarettes for people who had mental health issues and for prisoners because we felt like it helped them manage their anxiety. Then we kind of got on to yes, it causes lung cancer also, but as you probably know, um, stopping cigarettes can be more difficult than stopping some other types of drugs, and nicotine is a drug. Another issue with that is nicotine can change the way that the psychiatric medications work and interfere with that, so that can also be a problem. Other issues include social problems, stigma, just the perception that maybe there is something wrong with this individual, maybe they did something to cause this, maybe that they're dangerous, that they could be violent because they have a mental illness. Um, that is not common. While there is some violence, especially if someone is having psychotic thoughts or behaviors, but a person with mental illness is much more likely to be a victim of violence than to be a perpetrator of violence themselves. A lot of people don't understand that what the mental illnesses are and what kind of symptoms there are. And a lot of people don't believe that there is the ability for the person to recover from this, and that they're always going to have problems because of their mental illness. Isolation and loneliness is another problem. Again, uh, a lot of this comes from the fact that we have a stigma for mental illness, especially if they're not working, maybe not with their family. Mental illness can cause relationship issues also. And victimization, and like I said, they're more likely to be victims than they are to be perpetrators of crime on someone else. And economic challenges, unemployment, again, stigma comes into this a lot, that people are reluctant to hire someone who has a mental health diagnosis, or maybe behaves in a different way than we would normally expect. Part of recovery is helping people with their employment status, and using job coaches, training in order to help them to have a meaningful job where they can make money. Housing instability, again, there can be stigma against letting someone live in your housing because that they have a mental illness. And if they're living in an apartment or renting a house and there is some inappropriate behavior, a lot of times they're not allowed to return to that setting. And then there's a caregiver burden. Families who are involved in the care of this person, it can be very difficult for them, especially if they're parents who are taking care of a child who needs help in functioning. As they get older, especially, there's the concern when they can no longer take care of this person, or not there to let this person live with them, what's going to happen then. So it can be a big issue for the caregivers, for the taking care of them, helping them. There's also treatment issues, inability to recognize one's own illness. This is really common in the psychotic disorders. They believe what they are seeing, hearing, thinking is reality, and they really don't realize that they are ill. Again, this is another reason why they stopping their medicine is very common, because they don't feel like they need medication. We do have to tell people all the side effects that can happen from the medication, and informed consent for giving someone medication. And if I don't believe I'm ill and you tell me about all the possible side effects from this medication, I'm not going to see a reason why I should be taking this. So that can lead to that non-adherence. Some of the medication side effects, talked about that a little bit earlier, they can be pretty rough side effects for some people. There's, besides the movement disorders and the metabolic syndrome, there can be sexual side effects. There are some of the antipsychotics can cause changes because of the prolactin levels being elevated. Nausea, vomiting, drowsiness, being sedated is one of the big things that people don't want to be sedated, and a lot of these medications are very sedating. Not having enough treatment is also an issue. I think everybody knows we don't have enough available treatment for mental health. Um, Even with available health insurance, a lot of the times there's a long waiting period, even if you're able to get an appointment somewhere. Residual symptoms, things that even with treatment don't go away, are still there. And then relapse, chronic feelings of loss because of not being able to maybe meet those goals that they had originally in their life. So those can be another thing that is a problem with treatment. Some resources for people with serious mental illness. Uh, Comprehensive community treatment. A system that takes in all of their needs and meets those. Um, we do have um, several agencies that assist with that. Um, in the Peoria area, we have, besides our private counselors and psychiatrists, we also have Unity Place, which has multiple services for people from counseling to medication, um, reconciliations to uh, psychiatrist visits. And out in the community, we have case management. Case management happens with Unity Place through the ACT program, Assertive Community Therapy, where there is a case manager who is involved with so many patients, and they make sure that they get to their appointments, that they're taking their medication, and kind of help with whatever they need to facilitate them being able to live in the community and take care of themselves. That may be taking them to the grocery store. It may be being on call for an emergency in case they may need to go to the hospital, or maybe they just need somebody to talk to. So case management fills all those needs. Additional services and programs, psychiatric services, medical, somatic services, taking care of the medical issues that come up with the mental health. Case management we talked about, day programs, they may be drop-in programs. Um, It could be partial hospitalization for some acute issues where the person's not suicidal or homicidal, not going to harm themselves, but they need more treatment than you can actually get by seeing a counselor or seeing a psychiatrist, which may be, even if it's frequent, may not be enough. So day programs can fit in that void there. Um, Unity Place has Brighter Days, which is a drop-in area where you can just go and be with other people, play games. They have some little groups. You can also drop in at the living room at the crisis center. And the living room is just kind of a place that you can go if you need to talk to someone or just kind of get away and find a safe place to be. Group and individual psychotherapy, and then crisis intervention. In Peoria, we have ERS, emergency response. So trained people will go out into the community when there is a problem in the mental health area, and they will intervene, they will assess the issues, and come to a determination on what needs to be done. Does this person need to go to a hospital? Do they just need somebody to talk to a little bit? So there can be any determination from there. Maybe they need to go stay with a relative for a little bit, or maybe they need to go down to the crisis center and just be there for a couple days. So lots of different things that can come out of that crisis intervention. Some of these I talked about on the other slide. Emergency psychiatric services. The ER sees a great number of mental health patients. Housing services, helping people find a place to live. I talked about the partial hospitalization programs. They also in there get to see a psychiatrist, so having their medications evaluated to make sure they don't need a change. Community outreach programs. The ACT program does that. Some communities who are larger than the Peoria area actually have mobile treatment vans and things who goes out into the community, and they try to reach people, maybe bring them food, offer them shelter if they're homeless, offer them treatment, just kind of being there to bring people in if they can. And then substance abuse treatment. And we have several different places in this area for substance abuse treatment. We have a couple different detox places, one at Proctor at the Addiction Recovery, one at the Crisis Center. And then there are several treatment places. Proctor Addiction Recovery also does longer term treatment, as does Knowles for men and New Leaf for women here in Peoria. And then there's others like Gateway that are in our area, but not in the Peoria. So talked about at the ACT program, um, cognitive behavioral therapy. This started in substance abuse treatment and teaching people how to look at their behavior based on what they're thinking and to change behavior by changing how they're thinking about something. Cognitive enhanced therapy is computer drills and exercises. You'll see this sometimes on TV, telling people, if you want to prevent dementia, these computer exercises and games and things can help with your brain function. Family support is very important. NAMI, the National Association for the Mentally Ill, has a family-to-family program. They have educational programs, both for consumers of mental health treatment, done by peers, people who are not professionals, who have been in the same place as they are right now. They also have education for families. They have education for the community, and they have all kinds of other problem-solving things for families. They print a newsletter. You can join NAMI as a member and have access to all these different programs. Social skills training. Some of the mental illnesses will cause some cognitive issues, and social skills training can just kind of help with that, just to help them fit in more easily and kind of reduce that stigma. And then vocational rehab, if someone needs to learn a different profession, needs some help in getting employment, you can get job coaches and other things that can help someone get and keep employment, which can be really important to their continuing mental health. So advanced directives, while we're all familiar with healthcare power of attorney, living will, advanced directives in mental health, actually when the person is healthy, they determine who they would like to make choices for them when they are not healthy, and what kind of treatment they are willing to accept. And they draw this up as a legal advance directive. And then when it's determined they're not able to make their own decisions, that person can take over and follow their wishes. They may say which medications they want to take and which ones they don't. They may say where they want to be hospitalized. They may talk about which doctor they would like to take care of them. So kind of anything that they feel is important to their treatment when they are well, and then when they're not able to make those decisions, their person can do that for them. Guardianship is done through the court. People who need help with managing their own affairs. Guardianship, people with guardianship have a little less ability to initiate mental health treatment. Usually if you have a guardian rather than an advance directive, that has to go through the court. Talked a little about peer support. NAMI does a lot of that. The Human Service Center also does that, where they have educational groups that are run by peers, people who also have a mental illness who are doing well, and it can help with not only getting the message across, but to show people that there is a path to recovery here. Wellness and recovery action plans, putting together a plan with the patient, so what they're going to do to make sure that they stay well and what they're going to do with their recovery. Using technology to help with managing medications, making sure people remember to take their medications, remember their appointments, things like that. And then exercise is always a good outlet. In your book, you'll see some strategies for assessment of patients, some possible nursing diagnoses, and some strategies to intervene for patients. And you can just kind of read that in the book. Some current issues, outpatient commitment. Usually if the person is committed, even to take medication, once they are discharged from the hospital, that commitment ends. The only time this can be different is if they have attended mental health court or drug court, and the court orders them maybe to see their provider, to take their medication, and that is a condition of them not being incarcerated. So we don't have now any way to, does somebody who's non-compliant with medication and ends up having multiple hospitalizations, we can't get a commitment order just for them to take their medicines. It's hard to enforce that without the court checking on that. So deinstitutionalization and transinstitutionalization, taking care of people in the least restrictive environment. We used to have big hospitals for people with mental illness where they stayed sometimes for their whole lives. Years ago, probably 40 years ago or more now, we decided that we should take care of people in the community. So big mental hospitals were closed. We went to a community-based treatment, and that kind of goes along with this last one, inadequate access to care. We still don't have enough community treatment for everyone who needs it, even everyone who wants it. Definitely not everyone who needs it. And then this is the audience response question, and we'll talk about that in class a little bit.